Hello, everyone. Thank you for returning to Alimentos y Emociones podcast. Today we talk to Jack Birch on inequalities and behavioural weight management. Jack is a PhD student in the MRC Epidemiology Unit at the University of Cambridge, supervised by Dr. Amy Ahern and Professor Simon Griffin. Jack's PhD examines inequalities in behavioral weight management interventions using a mixed method approach. Jack completed his undergraduate degree in BSc Healthcare, Management, Policy and Research from the University of Southampton in 2018. His dissertation considered if practitioners in primary care were aware of and correctly applied the Chief Medical Officer's alcohol guidelines in consultation with patients. Following this, Jack achieved an MPhil in Public Health from the University of Cambridge, where his thesis looked at the equity of trials of smoking cessation interventions delivered in primary care. Jack worked as a researcher assistant in the Cancer Policy Research Centre at Cancer Research UK, where he was lead author of a report estimating that more than 100 million ready meals and takeaways were consumed in a week by adults in the UK. The report received widespread coverage, including being cited in Chapter 2 of the government's Childhood Obesity Plan. Please welcome Jack to the podcast. Right, ready?
Yeah, let's do it.
Right. Welcome everybody to Alimentos y Emociones podcast. It's really good to have you all back this week. And I'm very happy to introduce Jack Birch today. We're going to talk about a really interesting subject, inequalities and behavioral weight management. Welcome, Jack. It's really good to have you here.
Yeah, thanks for having me on. Really looking forward to it.
Well, we're just, let's start by just sort of diving into like your background and where where have you come from to sort of like start on this subject?
Yeah, well, it kind of goes back to when I was at school and college, kind of finishing off my school education, trying to work out what I wanted to do at university and with my career. I really wasn't sure, but I kept seeing lots of things about health policy in the media. I was like, oh, that's quite interesting. Maybe I'll look into that a bit further. And when I was 18 and looking at university courses to apply to, I found this course at the University of Southampton in the UK that focused on health management policy and research.
Yeah.
And yeah, that was my kind of gateway in at quite an early age. But and I found things so interesting. So that kind of focused on anything from how healthcare in the UK was structured to some of the more kind of public health issues, which is what really piqued my interest.
Yeah.
And kind of led to the next steps.
Great. And then you went on to do a master's. How did that work out?
Yeah, that's right. So as I was coming towards the end of my undergraduate degree, and I'd worked in research kind of during my degree as well, Cancer Research UK doing policy and behavioural research, but I was kind of really keen to pursue a research career a bit further. But when I was looking at PhDs to apply for, it came kind of apparent that a master's was needed to kind of bridge that gap. So yeah, that's when I first came to Cambridge to do my master's in public health.
And what did you work on then? You worked on what was it about? It was also about inequalities.
So I did my thesis on inequalities and trials of smoking cessation interventions. So basically, like through my time, I was like, okay, this concept and idea of inequalities really interesting. And in terms of kind of the interventions we delivered to people, I was already quite interested in that, and especially the ones that kind of delivered to groups from making it to be high risk of a disease. And yeah, the opportunities came to do that on my master's thesis. So I was really looking at how well kind of these smoking cessation interventions, this could be anything from things like e-cigarettes or certain medications, counselling, therapies, those kind of things, how well they worked in kind of different socioeconomic groups.
So basically you were in sort of like smoking cessation, and then how does this take you on to sort of weight management?
Yeah, so kind of, especially when I was working at Cancer Research UK, the team I worked in focused on kind of cancer prevention. So it was to do with obesity, smoking, and then other things like alcohol and sun exposure. So I already had an interest, and it was just a case that in my master's thesis, I kind of had to focus on one thing just because of the scope of it. And yeah, an opportunity came to stay in Cambridge with a couple of academics I met through my master's, and I got on well with, and we had some interesting ideas. And it was kind of taking perhaps the approach I took in my master's thesis into a PhD and being able to do it at kind of a deeper, more comprehensive level on a different topic.
Yeah. So now you're doing your PhD, and you're doing it, on these sort of health inequalities related to weight management, basically.
That's right, yeah.
So is it mainly weight loss or, weight maintenance, both?
Yeah, so it's a bit of both. So I think most of the interventions I've looked at in terms of like my systematic review work, but also in the unit I'm in, are focusing on weight loss.
Yeah.
And often kind of the more commercial style of programs such as Weight Watchers, Slimming World, those kind of things.
That's interesting to go into a bit. Sorry, I'm going to stop you there because it's just, maybe here in Mexico we're not so sort of familiar with that sort of type of weight loss intervention. I don't really know why it's not. Maybe the sort of health system doesn't partner with, like Weight Watchers or something, maybe to help with weight management. So
and that is one of the features in England, is that you can get 12 weeks of these kind of commercial programs funded through our NHS.
Oh, right.
And that's something that kind of general practitioners and people in primary care can refer their patients who have obesity onto.
So basically you could get onto Weight Watchers, like a Jenny Craig or something, or
Slimming World, Rosemary Conley, or they're also kind of like non-commercial versions of these programs that are run by kind of local governments in England and the rest of the UK as well, that take kind of a similar approach, these kind of dietary and physical activity advice and counselling and guidance into helping people with obesity to lose weight.
So they include the sort of weight management, the behavioural side as well.
Yeah.
And then does your unit as well carry out these interventions, these sort of behavioural weight management interventions by yourself?
Yes. Yeah. So they kind of, rather than carry out the interventions themselves, they've trialed various kind of styles of these interventions. So my primary supervisor, Dr. Amy Ahern, has in the past run a trial which has looked at different lengths of Weight Watchers versus kind of brief advice, and see how that affects people's weight loss and weight trajectories longer term. And then they've done other kind of similar work in people with type 2 diabetes and looking at weight loss in them. And then recently they kind of developed a more digital based intervention to help with weight loss maintenance as well. And that's probably when you asked, did I focus on weight loss maintenance? There's a slight hesitation because most of my work so far has looked at weight loss, but over the course of my PhD, I'm trying to look across the kind of trajectory of people's experiences throughout an intervention. So there's that bit at the end of kind of weight loss maintenance that I've looked at in terms of these weight loss interventions, but then I may also, if I have time, look at in terms of these kind of interventions specifically focusing on helping people to maintain their weight.
Okay, so I'm gonna sort of, in order to join with Inequalities, I'll ask you first sort of like, of all these interventions that you've managed to sort of look at, now what seems to be working the most, or what, or the ones that have been researched in your unit, what seems to have, a better effect? And then basically, like, have you found then that that inequalities have an impact on this? And maybe that helps us sort of jump into that.
Yeah, so generally, like, these kind of behavioral style interventions do work, and they do help people lose weight. And I think what the evidence has shown is that they are cost effective as well. So healthcare providers are happy to kind of fund and allow patients to go onto these interventions because they do work and they help people lose weight and they do improve their health. In terms of kind of, that's like the overall effect. And then when we're breaking it down by looking at, say, people of different income levels, the evidence is somewhat more mixed. And that's just because there's a lot of theory that suggests how these interventions may work in different groups, but the evidence hasn't really come out of that. So there's a theory that kind of suggests this idea of agency, and what that just means is kind of someone's ability to go and benefit from an intervention.
Yeah.
So if an intervention requires a higher level of agency to take effect, it means that someone's going to have to kind of spend a lot of time, potentially, personal income and resource on either paying for it, if they want to do it long term, or even things like buying the right foods, getting the transport there, and also things like kind of education and being able to understand the context that's being delivered. And it's kind of thought that through this agency mechanism, these interventions, so these behavioural interventions, which require quite a lot of that in order for people to benefit from that, may actually kind of make inequalities worse. So as in they perhaps would be more effective in people who are more affluent, got higher income levels, from areas of the country from like lower levels of crime, better health status, better schooling, those kind of things. So there's some suggestion these interventions might work better in those groups.
Ethnicity as well, or
ethnicity, yeah. So I think generally in public health, especially from a UK perspective, a lot of these interventions are kind of designed for white, affluent, in other areas of public health, men, but weight loss intervention is probably more geared towards women. So there's kind of very specific demographic that it's designed for, because that's who, in the last few decades, people in health decided to sign interventions for, because they didn't have all these kind of, there weren't these schemes in the past to making sure we're kind of reaching these other groups in society that have kind of been overlooked for too long.
Yeah, I think it's, something that we're seeing more and more, isn't it? Like actually people just talking about this now as well, which is really, I think is really important. To take everyone into account, which of course also makes it slightly more complicated.
Yeah.
Would you, well, hang on, let me get to that probably later. How would you suggest that you would modify the behavioral intervention, with, depending on the differences in inequalities? But let me get to that in a bit. If you, I'm going to go maybe to something that might appear sort of slightly simple or simplistic, but I just think that it's interesting, because when I think of agency, and this sort of ability to enact the content of an intervention, what would be like the difference between sort of agency and self-efficacy? Because there's kind of like, maybe I put you in a spot here, but I just think, well, that like differences in words and stuff, how different are they?
Yeah, I'm not too sure. So by self-efficacy, what are you meaning by self-efficacy?
I mean by self-efficacy that, the capacity that every individual has to actually carry out, a certain task or objective or an aim that you might have, and how confident you feel that you can sort of, do this. If someone says to you, right, we're going to do, such and such in order to help you lose weight.
Yeah, and I think ultimately, self-efficacy and agency probably are quite intertwined to an extent. And because I think maybe not specifically in terms of like health interventions, but there are certain experiences you have in life that give you advantages over others. So say you're from, a better, more educated background, so your parents went to university, you're white, those kind of things, I think they probably do enable you to have kind of a higher level of self-efficacy.
I think maybe the agency, I mean, just thinking about it now, maybe the agency is what, gives you better self-efficacy.
Yeah, Yeah, I'd say so. Yeah.
So then that could be like another thing to study for someone else.
Yeah.
Not
Yeah,
suggesting
definitely.
it for your own for your
Yeah, I
own
think my
PhD.
supervisor might have a panic if I suggest including more things.
You might start hyperventilating right now. So like, what? Another variable? Okay, so if the literature suggests that, you know, if you have more agency, then you would be more likely to make sort of like inequalities. No, is it if you have more agency, then you would make it less likely or more likely that health inequalities would be better?
So the more agency a person has, the more likely they are to benefit from an intervention that requires a high level of agency. And I think it's just the people that have a high level agency tend to be not deprived, whatever kind of
better off as far as inequalities go.
However you look at that. So actually, so these interventions that require the high level of agency to take effect, it's thought that, you know, they work better in these groups than they do in people who are less well off, and whatever definition you're looking at. So actually, like in terms of obesity, we know there's a socioeconomic pattern into it. So the more deprived you are, the more likely you are to have obesity. And then if our interventions work better in those groups that have a lower prevalence, then it potentially could make that gradient greater, actually worsening the inequalities in that prevalence of disease.
Okay. So, but obviously there's not a lot of evidence yet.
Not yet, no. And I think that's where my kind of PhD comes in, is that the evidence has kind of taken diet and physical activity and weight management interventions as a whole and tried to kind of look at them all at the same time. And that really means you kind of got a lack of depth of the evidence there that you can only really bring in when people are looking at those kind of single interventions in much more detail. And then eventually, once people have done that for enough of the interventions kind of across the spectrum, then you can really start commenting on how these interventions look and how they interact with these characteristics where inequalities occur.
You're really going to need a lot of people to be able to see
it.
And if they're all a certain, you know, sort of white and women and privileged to, you know, a certain extent, then you're going to find it kind of difficult maybe to see some of these differences.
Yeah, exactly. And that is the kind of,
that's the work that you did a bit in your, you know, in your systematic review.
Yeah, so that's the kind of thing I tried to look at. And then, but inevitably, when that's the kind of state of affairs for so many interventions that I was looking at, that they were predominantly white, they were predominantly women, they were predominantly affluent. It is actually quite difficult, even when you get lots and lots of studies together, it is quite difficult to start untangling some of those differences. And I think that's where like tailoring of interventions becomes a particularly appropriate and useful and really important to make sure that these groups are a lot less likely to either engage or attend in the first place, never mind actually benefit from an intervention, to make sure you can still get these kind of interventions to them.
So this tailoring in your mind would look like what?
It would look like making adaptations to the intervention on like several different levels. So it could be, you know, if you've managed to pitch your intervention content right at your user group, but you've got your intervention setting, it's based in a community centre that's the wrong side of the highway, and there's no public transport to get to it, then that location isn't very useful for a lot of the people with obesity who might need to access it. So it could be things like even just where you base your intervention is really important to make sure you're getting those people. But then so it's kind of pragmatic and practical things like that. But then it's also, you know, intervention content. So I've read some work that was conducted in the northwest of England, and it kind of interviewed people from a range of, you know, kind of income levels and that facilitated the interventions. And there's even issues with intervention content, right? Because it's kind of sometimes I think pitched at what we think the average level of understanding is. But actually what that does is either annoys the people who are, I say, have a high level of agency, a high level of understanding, because they're like, this is too basic, it's a waste of my time, this isn't very useful. But then actually it's kind of pitched at a wrong level the other way for people who haven't had those opportunities in life to develop kind of the understanding and the practicalities to be able to benefit from the content. And then sometimes by pitching things at the average, we miss everyone.
Yeah.
Or the majority of people.
Yeah. So you could pitch, I mean, obviously then you could pitch it. I'm a dietitian, so I think, like just culturally different types of food, or, I work with appetitive traits. So eat the traits that, the appetite traits that the person has, like how you approach food or something. So, just thinking in those terms, that would be a form of tailoring to the different inequalities, people's understanding of how to, Okay, so, I mean, it's so interesting and yet so complicated, because you're talking sort of finances, you're talking socioeconomic levels, you're talking ethnicity, you're talking differences between male and female, because, why is it that, that men don't participate so much?
And it's even things like pragmatically, you can't tailor it to the extent where every single person can benefit from it, because that would be one-on-one interventions, and I think very few places in the world would ever be kind of have the resource to be able to do that. But there's probably a happy medium somewhere we can reach. I was at a conference in the Netherlands last week, the European Association for the Study of Obesity. And these are the kind of conversations that were coming up with colleagues who have delivered interventions, and they're delivering the intervention to 30, 35 people in a room at once. And these people are on have a range of kind of educational understandings and abilities, and, life circumstances and complex kind of mental health needs and physical health needs. And that's just so far in a direction where it's really going to be difficult to benefit anyone, never mind a few people. And sometimes I think we can do a bit better than that.
And how do you scale it, as well, so that you could deliver it to more people? Because obviously 35 is just, kind of not enough.
I think the scalability is the tricky thing, because what works in one part of the world, part of a country, even if you look, socioeconomically, this is quite a similar level of income, it might just not work. And that's where like these other factors come in, like ethnicity, culture, language. Lots of interesting work from places like the US looking at language. The scalability is the challenge.
I mean, just cultural variability in the United States with the different languages is like a huge thing, culturally, all the different cultures as well in the UK as well. Right now, sorry, my brain is ticking, and so I'm trying to think of joining all these points together. How would agency or inequalities be related as well to adherence and effectiveness and attendance, So these sort of interventions.
So if we're thinking about kind of these more, these community or commercial or group-based interventions where you say you go for 12 weeks, there's a lot of factors that influence someone's ability to attend. So, if you think about someone who's on a low income level, they might have several jobs, they might need to get home and feed their kids when they get home from school. And then probably somewhere down that list, it's like, oh, this weight management session my GP recommended I go to, I should probably go to that. But I've been working from 7 a.m. to 7 p.m. Exactly. There's so many more important things in life that people have to deal with on a day-to-day basis, that often things like this can get kind of kicked down. So the attendance can be a real issue, getting people there in the first place. And then it's not just that, and I think it touches on perhaps cultural issues as well. But once people are given kind of advice, it's like, okay, you eat this kind of food, maybe it would be better if you try and eat this kind of food and prepare it in this way. that can have multiple issues. So that's more like adherence than intervention, but that could be things like, you know, I was reading in one study, people would go to like a local fried chicken shop because they can feed their family of 4 for $5.
Yeah.
And the recommendation instead is, oh, why don't you go and buy some nice lean steak, mince it up and make your own burgers? The healthier suggestion. But £5 to feed a family 4 versus however much that would cost to buy all the ingredients and then to actually prepare it. Just
The
economies of
time it
scale
would take.
different. The time it would take, exactly. All these things are really tricky. And then also on top of that, you have these kind of cultural factors that come in as well, because, you know, especially people who are from kind of certain immigrant populations, they don't prepare food like the
They're
kind of
not going to
average
mince chicken
person.
into a
No,
burger
exactly.
because
Or
it's not
they're
even culturally what they eat or anything.
exactly. So that kind of, they can't adhere to the advice because this concept's so different to what they're used to. It's just not really possible. And then that's where I think some of the tailoring needs to come in, or at least, even if it's not tailoring, having kind of more cultural sensitivity when delivering interventions. And actually, I think a lot of it's time, and it's time for everyone. It's time for the participants, but it's also time for the people delivering the intervention. So I'm sure if people had enough time to actually think about their participants' needs, they'd be able to take some of these factors into account.
Yeah.
And start giving advice that's a lot more kind of culturally and economically appropriate to the people they're helping.
Yeah, I mean, that is so important because, you know, it's also going to affect like the attendance as well. Or if you think about it, you know, you would have to base your intervention to a specific group that lives in a certain area that has certain, you know, inequalities, so that you could cater to those a bit more specifically, and then you could, for example, change the content of, you know,
precisely,
of everything, you know, what you'd be delivering, and, you know, just even like culturally based foods and stuff, plus income, plus, you know, where are you going to do the meetings? You know, I was just thinking right now, well, maybe, you know, like Zoom and stuff is probably sometimes easier. But then you lack, or you lose the sort of community factor, like the sensation of I'm doing this with someone else.
You
know, I'm not doing it alone, which also affects like that social support.
Yeah, definitely.
Wow. Okay, well, let's kind of close this off slowly. Where are you going from this? You've done this systematic review, which I will put the link to down at the bottom so that people can find you, as well as find you. And I'll also put links, you know, to your social media and stuff. But where are you taking your research from now?
Yeah, so kind of the systematic review was really the starting point of my PhD, and it was kind of a really comprehensive piece of work to identify the gaps that I could respond to in later projects, but also, just to work out what had really been done so far. But what it wasn't able to do is kind of give us more precise answers about which groups really benefit from these interventions and which groups we need to identify further. And that's because it wasn't kind of quantitative in nature. It was a what's the word? More of kind of a descriptive narrative study. So my next stage after that is to actually get more trial data than I've got access to in the unit I'm in, and pull that and then quantitatively analyze that, so I can really start honing in on the groups that maybe fare less well through these interventions. So that's just a UK-based study. So my systematic review was all OECD, kind of high-income countries, and then kind of narrowing it down to the UK after that. And then kind of following that, I've got two more projects. So one's looking at what happens to people a few years after they've gone through an intervention. So we know these interventions kind of work, you know, short term, a year, great, but maintenance of weight loss is a real issue, right? And it's kind of how quickly do people put the weight on once they finish the intervention. So I'm looking kind of at the 5-year follow-up from some trial data that analysed Weight Watchers to see if certain groups maintain their weight loss more so than others. And actually, I've completed the analyses on that. And its age was the main kind of factor that came out. So actually, younger people maintained less weight loss than older people, and perhaps that has interesting implications for the idea of agency, or probably time being the main factor. You know, they're working, they've probably got kids still, those kind of factors.
Or maybe they just haven't tried it quite so many times, and so they kind of like, they want magic.
Yeah, kind of a dose response effect, I guess, over time as well.
Yeah, so maybe the dose response just makes you feel like, well, I know this is difficult, so I might stick to it, you know.
Yeah. And then what I want to do to kind of wrap up my PhD is to do some qualitative work, start talking to people about why these things might be occurring. So I'm likely to be doing that in, not too sure yet, but maybe participants who have type 2 diabetes, just to kind of narrow it down a bit further and respond to the gaps in literature. But yeah, start to really understand why people are able to attend and why others aren't. Because actually in conversations I've had with other academics, with policymakers, they're really interested in the attendance. Because the outcome, I think, follows from the attendance more so than anything. But yeah, and that they're really seeing issues around
attendance and adherence, but then you would attend if it was catered as well, sort of for you a bit more. Just thinking about that. Right. I was just thinking of, you know, the comment that you just said about, you know, how you looked at the inequalities in the high OECD groups. I usually say it the wrong way around because I'm thinking in Spanish. Not groups, countries. But I mean, obviously they're sort of, you know, these interventions are geared in sort of higher income countries, because these interventions require a lot of money, and we don't have that much funding for.
No, exactly. And I think there are issues around obesity and malnutrition in lower middle income countries, and that's something that has emerged since kind of the nutrient poor, calorie dense foods from high income countries has filtered its way into these lower middle income countries. But yeah, these interventions really aren't designed to those kind of settings, and that's partly why I've had to kind of scope my PhD down that route. And not to say that we shouldn't be thinking about these things in these other kind of countries, but yeah, they're so resource intense that it's possibly not practical yet, or I don't know the ways, because I've not really looked into it, about how we'd go about delivering these kind of interventions in those settings.
I mean, I think they could be delivered, but we need the funds.
You know,
I mean, basically, it's not that, you know, the problems are there, you know, the people are there with their own culture and their own inequalities and their own factors, but, you know, we work in these areas, so we know those inequalities, we've studied them, we know the culture, we know, you know, or we're trying to find out as well, you know, what would the same thing as you're trying to do for the UK, but actually trying to get some money, you know, around to be able to deliver the interventions. That's probably why you didn't find very many when you were doing your research, your review.
Exactly, and I think that's why these kind of like systems-wide approaches to obesity is really important, because what I look at is treating obesity, but there's a lot more we can do to stop people from getting obesity in the first place. And
so I think that's examples.
So that is reformulation of foods high in fat, sugar, and salt. You know, there's various like sugary drink or soda taxes around the world to try and get people.
We have all of that here. We have soda tax. We now have you know, the hexagons on food labeling. Therefore, there has been a lot of reformulation as well now, because we're on for 2 years. So you see the difference when you go to the supermarket of like how, you know, the food used to be high in calories or high in salt, and now they're all of a sudden the hexagons have disappeared. So that we've seen some changes.
And I think that change has been really positive, but they're really hard to evaluate, these kind of interventions, because at these kind of the interventions I look at high risk groups, you can be like, okay, this probably caused this, but as soon as you blow up to that level, you can't really establish causation so easily, and that's where I think it requires a bit more pragmatism, but also lots and lots of these kind of interventions will hopefully add up one day to a food environment that, and not just food environment, but also kind of physical activity, active travel, these kind of things will eventually add up to something that actually has a notable impact on the prevalence of obesity and stop people from getting obesity in the first place. Because almost if we're having to kind of think about these style of interventions that I look at, it's too late from a public health perspective. We really want these interventions to be a lot earlier. And I think when we think about type 2 diabetes, that becomes a lot more obvious, right? Because it's okay, this condition really is associated with obesity, and the earlier we can get involved, is more likely we are to have to get somebody to no longer have type 2 diabetes.
Definitely. I agree. Well, I also think, that like collaboration between like more people, in a like individual way, in like research groups, in politically, and just more community work, not like, I do my bit, you do your bit.
Exactly,
pull in different directions, because this is a big problem for all of us, no matter where you are.
Exactly.
Anyway, that's my take. Jack, thank you so much. This is a really interesting subject. If people want to get a hold of you, what are your sort of social media? I will write them in, but
Twitter.
Where can they find you?
Twitter. I'm mainly on Twitter.
Okay.
So Twitter's the best place, at Jack Birch. And I tend to tweet about my work a bit, and DMs are open if anyone ever wants to chat.
Oh yeah, send them your way. This is a really interesting subject, and thank you so much for agreeing to participate on the podcast. Thank you.
No, thank you for having me on. It's been great.
And everyone else, thank you for being here, for showing up. And, there'll be more programs like this. And I just want to remind you that, we continue to nourish each other. So thank you all for listening. See you next time. Bye. Gracias por escuchar un episodio más de Alimentos y Emociones Podcast. No olvides dejar un comentario, suscribirte al canal y presionar el botón de notificaciones. Ayúdanos a crecer. Y recuerda, nos seguimos nutriendo.